Welcome to Ask Dr. Geier Live. That's right, it's that one time a week where I answer your injury questions, or maybe it's a family member's injury or something like that. Surgery, rehab, whatever it is, I'm happy to talk about it. And if you don't have any questions, then I'll just ramble on and on. My name is Dr. David Geier, double board certified orthopedic surgeon, sports medicine specialist, and media medical expert. I hope you feel and perform your best regardless of age, injury, or medical condition. I'll probably end up saying this about 5 times in the course of this this video session, live stream, whatever you want to call this. This is not meant for medical advice. This is general information and educational purposes only. Yes, I'm talking about the injury, the surgery, whatever it is that you have. Just know that it is meant for information so that you can take it home. You can go to your orthopedic surgeon or your doctor and say, hey, what about this? Whatever the ideas are. I actually had somebody, part of the reason I do this, and Jerry, I see your question. I will get to it here in a second. One of the reasons I do this is yesterday, literally, I had maybe a 30-minute phone call with somebody in Chicago, and no, I don't normally do that, but he had done something through our office where basically he paid for a visit even though it wasn't medical advice, sort of like this. But I realized what I remembered from all my time, 15 plus years as sort of a traditional orthopedic surgeon before I sort of pivoted a little bit to a little more integrative medicine, integrative orthopedics with the peptides and some of the stuff that we talk about. But he was calling me about his son, who's a high school, I guess, basketball player, I can't remember, who had dislocated his shoulder. And it became very clear that he didn't understand why he was being told his son needed surgery, what that surgery entailed, what the rehab entailed. It's because his doctor basically, it doesn't sound like could speak English, or if he could speak English, he didn't take any time explaining any of it. And I do feel like that's one of the things. One, I like to help people, but I also like to sort of translate information that people just aren't understanding from their doctors. That's why there's probably at this point now 3,000 articles and videos on my website. I don't know how many videos on YouTube, 600, 700. I've done a podcast, all this kind of thing. That's partly why I do it. So anyway, I hope that you appreciate this, but because of all the stuff I do, this is the only time and the only venue that I do it. There's no podcast version of this. It's not on Facebook or LinkedIn. It's not on my website. It is only YouTube, and it is only Friday, noon Eastern time. All right, so Magdeal, very good to see you. All right, Jerry, I told you I'd get to your question. 5 months post-surgery with knee pain and swelling. Stem cell or PRP therapy for a new tear. A couple things. What he's talking about, an anterior horn meniscus tear. Anterior horn is just the location of the meniscus. If you're looking at my, as I like to say, handy dandy knee model here, the meniscus is this C-shaped shock absorber, C like the letter C, on either side. The medial side, which is this one, let me turn this the right way, this is a right knee, or the lateral side. The anterior horn is front, toward the front of the knee. Most meniscus tears are toward the back of the knee. I haven't talked about it much. I'm going to do a video on this soon, actually, about when surgery for a meniscus tear can be a good idea, and very often when it is not necessary. And this has been shown in multiple studies since probably the first one I think was either 2007 or 2008. I want to say it was a VA study down in Houston, but it's been replicated in multiple countries now, and that is that people with degenerative changes in the knee, essentially arthritis changes in the knee, typically don't get any relief, or if they get any relief at all, from going in and trimming out a torn meniscus tear and cleaning up the cartilage. It is very short-term relief. But there's also significant concern and data to back this up that it actually speeds up the process and makes people better long-term. So, and again, this is not medical advice, Jerry, but typically surgery is not the answer for patients that have what you describe. Now, PRP and stem cells are sort of two different ideas. They're both regenerative medicine. PRP is the procedure where we draw up a little bit of blood. The blood goes into a syringe. The syringe we put it into a centrifuge, spin it around, which filters off the red blood cells, the white blood cells, leaves the clear yellow part of the blood, the plasma, and that has growth factors and other things to initiate healing. That is thought to be very good. And I did a video of this it's in the Modern Medicine playlist, about a third of the way down on my YouTube channel, which is, let me show you that in case people want to know that. It's youtube.com/Dr. David Geier. There is a modern medicine section, and there's one on PRP for arthritis. And what you'll hear me explain in that is PRP is very good at building up what's called the extracellular matrix, the matrix that holds all the cartilage cells in place. And I have had very good success, and I think there's a number of studies out there that show very good success for early arthritis. Stem cells are the idea of trying to grow new cartilage, getting precursor cells that turn into bone, that turn into cartilage. Stem cells in the United States haven't been terribly effective, at least according to the studies that are out there. One, there's a surgical procedure involved to harvest them, which isn't much fun. But more than that, in the United States, we're not allowed to culture stem cells like you can in the Caymans and in Germany and all these other places people go to get stem cells, where they can take the little specimen that they get from that procedure, take those 100 stem cells, cultivate them or replicate them in a lab, and basically turn it into 1,000,000 stem cells. It's fine, and I think there is a role for that, but where you might go that's sort of the next thing, and I know just like stem cells, this is not FDA approved either, but that is a treatment called exosomes, and I've done a video on that as well. Check that out in Modern Medicine. That is what stem cells are delivering to grow new cartilage, to grow new bone. The stem cells release their exosomes. Well, you can give an injection of exosomes that come, usually orthopedic surgeons and these integrative medicine doctors get it from amniotic fluid, and it's got millions of those exosomes without a surgical procedure and without doing anything wrong in terms of culturing stem cells and things like that. So that's an option. One thing about stem cells and exosomes that I feel like is neglected in these regenerative medicine clinics, and Jerry, you're probably like, holy cow, this is way more than I wanted to know. But one of the challenges and one of the reasons I think stem cells haven't done well in the research in the United States is that it's not the doctors are not addressing the underlying inflammation that's going on in the knee. If you've got a chronic inflammation going on, whether it's obesity, it's a poor diet for a long period of time, not exercising, chronic stress, and you have all these inflammatory cytokines, interleukin-1 beta, interleukin-6, tumor necrosis alpha, floating around your joints, around your knee, wherever it is, the stem cells will help, but those inflammatory cytokines are still going to eat up the stem cells just like they eat up sort of healthy cartilage. So you've got to do something to stop that inflammatory process. So something like penisin polysulfate, there's supplements that do it like epigallocatechins in green tea, curcumin can help with that, but those can be very important. In fact, next Thursday I'm doing a Better Than Ever Live on supplements for osteoarthritis, and we'll talk a little bit about that. But check out my Modern Medicine playlist. I talk about penisin, I talk about exosomes, I talk about PRP, all as options for early osteoarthritis. Okay, Syed, I apologize if I said that wrong. TPF type 4, I'm assuming, correct me if I'm wrong on this, but I'm assuming you mean tibial plateau fracture a year ago. Can I return to sports? A year ago. It really depends on, and I say this a lot on this show. One of the challenges when people say, hey, it's been 6 weeks, it's been 6 months, it's been a year, can I return to whatever? The absolute amount of time out from the injury, out from the surgery is a good thing to know, but it really has no bearing on when somebody can start bearing weight, when somebody can start running, when somebody can start playing sports, when somebody can go back to work. In this case, the kind of the criteria that you would look for: 1, the fracture completely healed; 2, the joint surface being well, you have full knee range of motion without pain, full strength, and then the ability to do sport-specific movements. And that's something that time alone a lot of times is not enough. A lot of times that's working in the rehab process with a physical therapist to get that motion back, to get that strength back, to test those sport-specific movements and go from there. Typically with tibial plateau fractures, you're talking in about 4.5 to 5 months after, 4.5 to 6 months maybe, after the injury and after the surgery. But again, the amount of time is not what you're looking for. It's all those other criterias. All right, Dawn in California. Thank you, Dawn, for telling me your first name and where you are. I really appreciate that. Look, another tibial plateau fracture, plate and 10 screws. returning to running. So it's a little bit like what I was saying with Syed. So, and those of you that are wondering what a tibial plateau fracture is, if you're not Don or Syed. So this is the knee, all right? Let me move the quad tendon, the patella, and the patella tendon out of the way. So you have the femur, the thigh bone, the tibia, the shin bone, the top of the tibia at the sort of the under surface or the supporting surface of the knee joint is the tibial plateau. You typically break it on the lateral side, out on the outside, but you can break it on the inside, and type 4 actually is a medial plateau fracture, which typically is much higher velocity injuries. A lot of times have more nerve and blood vessel damage with a type 4 tibial plateau. Can be a big problem, but it's treated, as she says, typically a plate and screws. That one of the challenges with a medial tibial plateau fracture, sometimes the hardware can be irritating, so not infrequently people have to go in and take the plate and screws out and then wait for that to heal. But as far as returning to running, it's a little bit like I said to Syed. It's got to be completely healed, and then you start a progression of getting your motion back, getting your strength back, sort of walking on it normally, and then trying it out running. And my experience with that is, again, running maybe 4.5 months, but sometimes it's a little quicker, sometimes it's a little longer, just based on how, not everybody heals the same way. And again, that's a significant weight-bearing part of the lower extremity, so you've got to make sure that that's healed before you try to run. Robert's good to see you as always. Very, very much appreciate you being here. All right, Magdeal, my fibula is not healing now about 3 months later. What are the ways to speed up healing of the fibula? So what Magdeal, and I apologize if I'm saying that wrong. That's what it looks like, but if I'm saying it wrong, I apologize. So this is the ankle joint. This is the tibia, the lower part of that bone I just showed you. This is the fibula, the small bone on the outside of the ankle. And that almost always is broken down here at the ankle. When I was in college, I broke it's called your lateral malleolus, the tip of your distal fibula. Now you can break it up here with a direct blow, something like that, or with a tibia and fibula fracture. But if it's just the fibula, it's almost always down at the ankle. Now, why somebody doesn't heal that's a little unusual, because that bone does typically heal on its own. And I'm not saying this is you, but the things you worry about when a bone is not healing, especially one that normally does heal, you think smoker, you think somebody that uses a lot of anti-inflammatory medications like Advil or Aleve, you think infection, you think maybe the gap between the bones is more than it should be, and if that's the case, maybe you go in. Well, regardless, if it's not healing, at some point you have to make a decision about, all right, is this going to heal on its own? Whether it's a bone stimulator or just more time. By 3 months, it's hard to imagine that may be it. But again, this is not medical advice. Or do you go in and do a surgery where you line it up properly, put the plate and screws on, and maybe add bone graft to stimulate the healing? And so 3 months may not be by definition what we call a delayed union, but it's certainly getting up to that. So those are some of the things. Now, part of it too is sometimes x-rays lag behind what the bone is actually doing. The bone may actually be more solid than the x-ray shows, because the x-ray doesn't show the early, what we call callus formation, the early healing bone. It won't show that until your body starts to calcify it, and that tends to lag behind a little bit of what's going on in a healing fracture. Richard, what to do popliteus? Tell me a little bit more about that. I'm not sure. Your popliteus is tight. I'm not 100% sure I understand what the injury is. Jerry asks, when would prolotherapy be used? So actually, it's interesting you said prolotherapy. PRP is a type of prolotherapy, but prolotherapy was first started, I want to say it was down in Mexico where this got a lot of attention, but it was originally injecting sugar water, dextrose, into an area to try to stimulate an inflammatory response. This is something you typically do into tendons. The extensor tendon right here for tennis elbow, maybe the Achilles tendon, maybe the patella tendon, an area where you have not so much an inflammation of the tendon, but you get a small area of degeneration within the tendon. And what that sugar water does, PRP is a form of prolotherapy, but you're actually injecting cells that would try to get it to heal, but you're trying to stimulate an inflammatory response to increase healing. The healing process starts with an inflammatory reaction. All these monocytes and macrophages and neutrophils that invade the area to try to basically start a healing process, scar tissue and laying down collagen, resorbing the necrotic tissue, that kind of thing. And so prolotherapy, PRP, are thought to be ways to speed that process up. I've never been a big fan. In fact, I've never done it personally with the traditional sugar water, the dextrose, but PRP can be very effective as a form of prolotherapy for that particular issue. Excuse me. Let's see. And I hope that's answering your question. I kind of just giving you my thoughts on it. Minimizing pain after the fracture, it just needs to heal, basically. I mean, I don't know too much other than that in terms of getting a fracture to not hurt so much. It's just got to heal. Now, like I said with Dawn's question, sometimes the plate and screws can be painful because there's not a lot of muscle there. There's not a lot of fat there, especially right below the knee. So sometimes you have to go in and take maybe a couple screws out or take the whole construct out at the time. Richard's from Portugal. Very cool. One of the shows that I'm a big fan of was in Portugal the other night. I thought that was really cool. I do. Tell me a little bit more about that. I'm not 100% sure I understand what that is. What I assume that's a form of running, a form of exercise. Tell me a little bit more about that. You're very welcome, Don. 8 months after surgery, return to biking, walking up to 3-4 miles at a time. Recovery is slow and painful. A return to running would bring me joy. There is nothing. So I don't do much surgery anymore because I focus on ways to try to keep people from needing surgery. I did that for 15 years, and I loved it. But you get to a point where you don't necessarily want to just be in the OR all the time. But one of the reasons I really loved orthopedic surgery and sports medicine was just that thing, the ability to finally tell somebody they are cleared to go back to sports, cleared to run, and just the excitement, the joy on their face. There is nothing better than that in all of medicine, at least I would argue. Yeah, the OB-GYNs might talk about childbirth, but that's, I don't know. I like what we do. All right. Okay, I got you. So running, okay. Pain behind the leg. I've been underwhelmed with the popliteus as a cause of calf pain. I suppose it can be, especially in a certain location. Generally, my experience is far more common that it's a soleus issue, sometimes a gastrocnemius issue, but it depends on kind of where you are. Sometimes stretching can be helpful with that. Sometimes foam rolling and things like that. But I'm pretty quick as a sports medicine physician to get somebody to a physical therapist because a lot of times they may find something else going on that is a referred symptom of. Maybe it's up at the hip and that's leading to a problem down at the knee or at the leg, something like that. As that the tightness in the back of the leg is the effect, not the cause. I don't know in this case because I can't examine you, but that I would be thinking potentially about seeing a physical therapy. Obviously, I'm not from Portugal. I have no idea how the medical system works in most of Europe, but I've got to believe it may not be called physical therapy. It may be called physiotherapy. I say that from my time as the chief tournament physician for a women's tennis tournament, and they were physiotherapists that came on tour with them, but that is my experience. All right, what else? I'm going to hang out for another couple minutes and then let you guys go. While we are doing that, remember, I said this yesterday, I will not be here Tuesday for Better Than Ever Live. I will be seeing patients at our Charlotte office for the morning, I guess. So I won't be back in time to do it, but I will be here Thursday talking supplements that can be helpful for osteoarthritis. I will be back here Friday at noon Eastern next week. Living in Florida, trouble with your lead knee and misplaying. Yeah, that's tricky with golf because the problem with the lead knee, I don't know that I'm going to be able to show this effectively, but that's where all the torque is going in a golf swing. If it's your trailing leg, whatever, if you're right-handed, then it's going to be your left knee that's going to be your lead knee. It's going to be painful, especially that's one of the problems with a meniscus tear, which is so involved in twisting motions. And so, yeah, that can be a tricky thing. But look into PRP, stem cells. I have a lot of patients in Florida that come up here to Charleston to see me when we talk about some of these things that most orthopedic surgeons haven't even heard of. And I know that because I'm not going to say who it is, but somebody very close to me saw an orthopedic surgeon in Florida yesterday, and she mentioned penisin polysulfate, and he had no idea what she was talking about. So I don't know that there's a lot of that. There's a lot of regenerative medicine clinics, but there aren't that many orthopedic surgeons that are doing some of these things. So I am happy to do that. If you, Jerry, or anybody else want to come see me, I see patients in Charlotte and Charleston, but for people out in the other 48 states, they come to our Charleston office. Information is in the description below this. All right, whatever else. All right, last one. This will be the last one for the day. I don't know that I can give you exercises because I'm not a physical therapist. That would be one. You could try searching YouTube. My experience with physical therapy exercises on YouTube is they don't work terribly well if you don't do the technique perfectly, and that's hard to get from a video. So again, I don't know what the healthcare situation is like there, but what I tell people here in the United States, find a really good physical therapist that rehabs athletes and just go for one visit, have them do a full eval, and then give you a list of exercises showing you how to do each one with the proper technique, and then start doing that on your own. All right, Akash, I'm very happy. My fan from India, I very much appreciate that. If you like me doing these, Akash and all of you, would very much appreciate it if you'd click the like button. It helps more people find this, and then I can help more people. Really, really, really enjoyed being here today. I hope this was helpful. If you still have questions, or you know people that have questions, I'm here every Friday at noon p.m. Eastern. Tell them youtube.com/Dr. David Geier. Make sure to subscribe. Click the bell to be notified, because sometimes I do sort of spontaneous live streams, and it'll tell you when I release a new video. I hope you have a wonderful weekend. I will not see you again until Thursday at noon for Better Than Ever Live, but I hope you have a great